Welcome back to Cardio-ECHO, Tackling Type 2 Diabetes. I'm Jessie Lewis, the clinic coordinator. And I think with that, I'll just turn it over to our facilitator, Dr. Dungan.
Good morning, everyone. I'm Kathleen Dungan, endocrinologist at Ohio State University. So I will be facilitating this session. And I would like to introduce the other members of the ECHO Hub team today.
I'm Gautam Rao. I'm the director of the ECHO program for cardio.
Good morning. This is Joshua Joseph from Ohio State. I am a diabetes and endocrinologist here and focus a lot on diabetes and cardiovascular disease from a research perspective. Good morning. Can't wait to present.
Good morning, everybody. My name is Adam Przinski. I'm a medical sociologist at the Metro Health System and Case Western Reserve University, where I primarily conduct research on how social factors intersect with clinical factors to influence health outcomes. And that often leads me to looking at health disparities.
And then finally, our case presentation today will be done by Dr. Terry Brody. And without further ado, I would like to present our didactic for today, which is the impact of type 2 diabetes on minority populations. And I believe, Dr. Joseph, you'll be starting this out.
Yes, I am. That is correct.
Great.
So good morning once again, everyone. I, on behalf of my co-presenter, Dr. Przinski, look forward to an engaging discussion on the impact of type 2 diabetes on minority populations. So the learning objectives here are to list and describe which subpopulations are especially high risk for type 2 diabetes, describe the role of culture, health beliefs, and socioeconomic factors upon the role of diabetes in minority populations, and describe a culturally sensitive approach to communication about diabetes management in minority populations. And so when we think about the continuum of diabetes care, right, it's a whole span here. We know that there is a great emphasis on and need for emphasis on reducing disparities. And that really, we talk about diabetes as being one of the conditions that disparities impacts it all the way throughout the entire spectrum, from incidence and prevalence all the way through mortality. And so today we'll focus on 5 different pieces. The 5 whys as one of the root causes of disparities, healthcare provider patient communication, non-medical health related social needs, and then cultural humility, implicit bias, and discrimination. So in thinking about the 5 whys, the 5 whys is a method of determining the underlying reasons or root causes of an event or occurrence. The pro for this is that it's quick and it leads to thinking kind of well below the surface, right? And a con to this is that it's largely conjecture until tested. It can be subject to bias when conducted with very homogeneous teams. So thus there is a need for heterogeneous teams and diversity of thought within the teams that perform any 5 whys activity, as well as a focus on equity for those teams. So this is an example. So we have our patient with diabetes that did not come to the clinic for a follow-up appointment. So the question is why? So in this case, the patient did not believe he really needed to come in. Well, why is that? The patient did not feel any discomfort and thus determined the appointment was unnecessary. We know in diabetes that you really don't get discomfort unless you're really inadequately controlled or you're developing long-term complications. So the patient does not understand the need for monitoring and follow-up care. And so thus this patient was really focused on the short-term relief of symptoms rather than the long-term plan of treatment for health. And so when we think about the root cause here, a cultural norm for this patient is to see a doctor only if and when there are visible and uncomfortable symptoms occurring. And we have one caution here, and that is that if your last answer is something you cannot control, you go back up to the previous step before, right? So if you can't control that last one, you go one step up and then try to address that. And so we want to really avoid fixing symptoms overall, right? We want to avoid those surface level issues that we're all facing in care and really get to the root causes. So really going below the surface. And we want to ask why at least 5 times. In addition, we want to think carefully about how social factors are often fundamental causes of disease and disparities. So this quote from Edward Honnett is, if you don't ask the right questions, you don't get the right answers. A question asked in the right way often points to its own answer. Asking questions is the ABC of diagnosis. Only the inquiring mind solves problems. And so here we'll focus a little bit on the neighborhood environments and diabetes risk and control. And this was a study, the senior author, Ana Diaz-Rue, is the dean at Temple of Public Health there. And they're thinking here about the neighborhood and socioeconomic status, how that then influences the social environment, whether that be safety, social norms, healthcare access, et cetera, as well as the built environment, right? So nutrition and physical activity and alcohol and tobacco environment. You think about sidewalks here and safety with physical activity, et cetera. And then how all of those things, right, influence diet, physical activity, obesity, onto risk of diabetes, diabetes control, and diabetes complications and outcomes, right? And so it's all a spectrum, right? Really starting with a number of those upstream factors, including the environment in which someone lives, and the environments that really they grew up in and that they participate in every day. And so here we have a paper that is now published called Casting a Health Equity Lens in Endocrinology and Diabetes, where myself, Dr. Sharita Golden from Johns Hopkins and Dr. Felicia Hill-Briggs from Johns Hopkins really went through and discussed, what are those historical drivers that are impacting health outcomes today. And I won't go through all of it here, but it's important to note that, there are a number of medical and scientific contributors. There are a number of social conditions and policies. We often use the example of redlining. Just as for instance, I could use the redlining data from Cleveland, where neighborhoods were sectioned off into an A, B, C, D, with D being the red areas of town where individuals had a really difficult time getting loans. I can look at that same data where redlining existed and look at health opportunity index today. And what we see is that where there was redlining, there is lower health opportunity for those in Cleveland. I could do the same thing in Columbus, Dayton, Cincinnati, and many other cities across Ohio. What's also interesting about this is that we have maps where we look at redlining, health opportunity index, and diabetes outcomes. So we can show that, for instance, our diabetes emergency visits are higher in areas that have been redlined in Central Ohio. And so these have kind of long-term impacts. Well, how do they do that? Through many factors, including structural and institutional racism, healthcare provider bias, trust in the medical establishment, and also language and communication barriers are really important as well. These contributed to that next line down in purple there, the healthcare context and the physical context, which I was discussing on the last slide. And those all lead to increased stress, blood pressure, obesity, cholesterol, and blood glucose. So all those things being critical in diabetes, because we know we treat the ABCs of diabetes. And within that, when we're thinking about outcomes, heart disease is the leading cause of mortality within diabetes care. And so next, let's talk about the healthcare provider-patient communication. And so self-management is really essential to optimizing health for individuals with chronic conditions. And those self-management behaviors include everything from healthy eating all the way through healthy coping. And so when we look at person-centered care, so this slide is really describing, adults who had a doctor's office or a clinic visit in the last 12 months who reported poor communication with health providers by race, ethnicity, and income. And this data comes from 2002 to 2013. And what you can see here is that on the left side of the slide, the Latinx or Hispanic population in this study reported higher levels of difficulties with poor communication with healthcare providers, right? And then when we look on the, and that was followed by kind of the Black subgroup in this study. When we look on the right side of the slide, we can see that those who were poor or low income had much higher rates of poor communication with health care providers compared to those with higher levels of income, right? So if you're a racial ethnic minority or your socioeconomic status is lower, there is poor communication or poorer communication with healthcare providers. And so does this matter? Does poor communication matter? Does concordance, right? And this is race, ethnicity, or language concordance, right? Do these things matter? So when we look at all cardiovascular disease medications, and when we look at, kind of Black patients versus non-Black patients, Spanish-speaking patients versus, other groups, et cetera, what we see is that it does matter, that there are, lower rates of, cardiovascular disease medications. I'm going to use the word, taking instead of adherence, but the ability to take cardiovascular disease medications in those who had, poor concordance. We also see the same thing among the Spanish-speaking population versus non-Spanish speaking. So if you had a Spanish proficient PCP, you were more likely to be taking all of your cardiovascular disease medications than if you had a non-Spanish speaking primary care provider. And much of this goes back to, and Adam and I kind of talk about this, a lot, it's not only, racial ethnic concordance, it's not only cultural concordance or language concordance. It's really about, shared experiences, right? And being concordant on many different levels, right? So we've talked about, in my visits, I might see someone who is from, Southeastern Ohio, who, I may be one of the first Black people they've ever seen in person, right? And I have to build concordance, right? So I may talk about some of the local restaurants. One of the things I do is I try to memorize all the mascots of high schools. So I talk about, a mascot of a high school, right? And I'll talk about maybe some of the facilities and that are in their local towns, or I'll talk about my 4-year-old. Maybe they have a 4-year-old. But how can you kind of build concordance in visits? So the evidence on concordance is nuanced. So there is inconclusive evidence to support that patient-provider race concordance is associated with positive health outcomes for minorities, right? So it's still inconclusive, it's mixed. Communication rated as more collaborative in race discordant relationships was associated with better adherence, while communication rated as less collaborative was associated with poor adherence. There was no significant association between adherence and communication in race concordant relationships. And then experimental studies suggest that race-sex discordant providers practicing empathy, collaborative communication, and self-disclosure. And so that I have a 4-year-old, you have a 4-year-old, that's that self-disclosure piece, can build similar levels of trust as concordant providers. And so next, I'll talk about non-medical health-related social needs. And so coming back to that, earlier CDC-based data, here we have care affordability. So people under the age of 65 who were in families having problems paying medical bills in the past year by poverty status and race ethnicity, right? And so what you can see here is that when you look at the poor or near poor compared to those who were not poor, you see much higher rates, right? And then when you look at, kind of white, Black, Asian, and Hispanic, you see that the Black and Hispanic groups are higher than the white and Asian groups. And this is very similar to data that we see in Ohio. I know this is national data, but there's very similar data here in Ohio. And so lastly, let's talk about cultural humility, implicit bias, and discrimination. And so when we talk about pursuing cultural humility, we're really thinking about the ability to maintain an interpersonal stance that is other-oriented. So this is kind of open to the other and their perspectives in relation to aspects of cultural identity that are most important to the person. So this is a little bit different than cultural competency, where you kind of are competent in the culture. You understand the culture. You've maybe read about a culture. This is really that ability to maintain an interpersonal stance that is other-oriented, right? So you're really thinking about a situation from the other person's perspective. And in practicing cultural humility, and this slide's from Sherry Ann Burnett Bowie up at MGH, we should ask questions in a humble and safe manner, seek self-awareness, suspend judgment, express kindness and compassion, support a safe and welcoming environment, and really start where the patient is at. And that's been a kind of a common theme throughout this ECHO series, kind of really beginning where is the patient, and then how can we move forward together? And so some of the potential solutions, are mitigation of implicit bias, effective patient communication, and building trust, the naturally, culturally, and linguistically appropriate services and standards, including the CLOS standards. And we've outlined those in our article, The Casting Health Equity, a lens on endocrinology and diabetes. We've outlined the ones that really particularly align with diabetes care, so I'll point you there as a reference. Streamlined evaluation and referrals to address non-medical health-related social needs. So how can we really address these social needs, but in a streamlined manner, right? We understand that everyone is in a crunch for time, particularly in our current environment. So how can we do this in a streamlined manner where you can put in a referral, and that referral goes to an agency that really can connect with that patient and address those non-medical health-related social needs. So we are blessed here in Ohio that the Medicaid managed care programs actually pay for a closed loop referral. So they can actually, provide dollars to those connected care or community care agencies. Community health workers that can do kind of, two things, very beneficial in addressing social needs. So many of those care agencies have community health workers that are attached to them and are really integral in addressing those social needs. And then also diabetes education with many interventions, particularly in some of our disparate groups here in Ohio, including Latinx or Hispanic American populations, showing that community health workers can have a great benefit on diabetes education. And lastly, kind of community engagement and patient advocacy groups. So when we think about the communities that we're serving, what things are really important to them? And beginning with that as the cornerstone of how we build out and advance care and improve care together. One way to think about that is individual community members and community organizations. Another is local patient advocacy groups and working with those patient advocacy groups. And so I'm going to kind of talk through these. So one of the pieces that we have been working on here at Ohio State and really many other institutions across Ohio is making anti-racism a core value in medicine. So really elevating the cause, engaging with stakeholders, equipping communities, employees, and learners, and empowering those who are marginalized or oppressed, as well as evaluation and accountability are key really across all of those aspects. We put two references there that you're happy, to check out to kind of learn more about really making anti-racism a core value. I will say it simply, and very simply, it's that equity has to be a part of every conversation, right? Not a subcommittee, not something that policies are sent to, but really germane to the beginning of those conversations are equity. And so establishing a collaborative relationship to assess and address self-managed behaviors without blaming patients, not using words like non-compliance and non-adherence, right? And we've talked about that previously, which really denote a passive and obedient role of a patient with diabetes. So kind of this kind of following a doctor's orders, using a non-judgmental approach. And that comes back to that kind of cultural humility and building collaborative relationships. And then using evidence-based approaches like motivational interviewing. So the CLOS standards are national standards that aim to improve healthcare quality and advance health equity by establishing a framework for organizations to serve the nation's increasingly diverse communities. And when we look at this streamlined evaluation, as I was mentioning earlier, really screening and referring models for caring patients' social needs. There are vendor-based systems like the Pathways Communities Hub models. There are simple kind of EHR-based screening protocols in Epic, for instance. And then we have to think about the existing processes, especially forms where you are already providing social care. Adam makes a huge point of that we're already doing a lot of social care. How can we improve the existing processes as well? And so for community health workers, these are our frontline public health workers, typically trusted members of communities. And the DE really describes them as complementary healthcare workers who interact with people with diabetes and those at risk for diabetes. And so here we list out some interventions that I was mentioning earlier so that you can have the references. But really all of these references really show that one interesting thing about community health workers, it's pretty high touch. They have to really be integrated into the care of patients or in the community and providing a good amount of care. It's not just a one-time, one-off. These are kind of long-term kind of collaborative relationships and partnerships that have shown reductions in A1C. And so there are many other possible solutions, and it is critical to think through those aspects of social needs, community factors, and health disparities that are most relevant in the hyperlocal circumstances of your clinic and the neighborhoods that it serves. So thank you so much, and we are open for questions.
Thank you so much, Dr. Joseph. So I will open this up to questions.
I was going to ask a question actually to my co-presenter, Adam. One of the things we talk a lot about, non-medical health related social needs and addressing them. And I think that one of the challenges is the how, right, Adam? Where, we have clinics who are all the way from, basically, solo practitioners all the way through, large academic, health systems and other private health systems. What are some of the approaches and ways to think about the how a little bit, Dr. Brzezinski?
I guess one of the first things that I think about is like, especially given just the diversity of types of practice locations and workflows, EHR systems, partner organizations in your region. So the first question is just is sort of the starting question, right? Like, how do you in your practice get started talking to your patients about their social needs, screening them for social needs, and referring? And in some places, it's going to be like, oh, we're rolling out like a standardized questionnaire for social needs screening using our EHR, and we're going to push it out via MyChart before. And then other places like can't even dream that would happen because like that's just not like in the playbook for this year. But you may start in a different way. And Joshua highlighted this bullet point about forms, and this is one of my favorite topics, which is physicians are often asked to sign like all kinds of forms, but as it turns out in some of my teaching, what we discovered was that almost a majority of these forms are forms that address social needs. So it could be a home energy assistance program form that allows somebody to have their utilities paid for in their form. And really all you have to do is like sign that form. So thinking like, so starting would be like, well, in my practice, like how good of a job do we do at making sure that when our patients have those sorts of needs and forms, that the right form gets completed at the right time and submitted to the right agency in the right way. And so like there can be some really simple points of starting. And then the other part about starting though that I really sort of like to emphasize, and we heard this, we did some focus groups among patients at Metro Health when we were first kicking off social needs screening, is how important it is for your whole team, not just the physicians, to really place the dignity of the patient first when you're asking somebody whether they have food or whether they have enough money, because it might not be you who's asking those questions or handing out those forms or receiving the answers or talking to someone. And you really have to put dignity first above everything. And it really gets back to Joshua's comments about cultural humility, so that even, and it might be tricky, like how can you stay humble when you're asking someone whether they are going to run out of food this week? But I think that's really sort of paramount and necessary. And as long as you're approaching it in that manner, and that's one of those areas where like the common ground strategy generally doesn't work as well for folks who work in healthcare and our physicians, because most of us are not running out of food this week. So that like we're going to have a harder time, but we really need to sort of be humble and then think about what are the resources that we bring and the understanding that we bring. And I'll just point one, just sort of last statement, the ADA guidelines that were published in that issue of diabetes care that Joshua highlighted at the beginning. One of the things that I found interesting that they note in that guideline paper is that they say that it's important to recognize and learn about your patient's social needs, even if you do not have the resources to address all of them at that day, at that time in your clinic, because it gives you an understanding of how to build a sort of therapeutic regimen and treatment plan, and how to recognize that this person in front of you may not be able to do all the things in the same way that every other patient or that some other patients would be able to because of resource constraints, whether it be transportation or family supports or ability to get to and from the pharmacy or to eat certain foods at certain times of day. So that really there is value in talking to people about their social needs, even if you're not yet a Pathways Community Hub, even if you haven't signed up with a new vendor and you have sort of two-way social, sort of confirmation of social needs referrals being fulfilled. It's still valuable to sort of start working on it and sort of get off the dime and get moving with that.
So there are a couple of chat coming in. What's the better term to use to replace non-compliance or non-adherence? So great questions, and sometimes that requires some wordsmithing. Joshua, what do you think?
Yeah, so both in the patient visits and in my notes, I talk about the ability to take medications consistently. And the reason why I kind of frame it in that way is, that leads immediately to a discussion of what are the barriers, right? Whether those barriers are being able to get the med from the pharmacy, whether those barriers are side effects to the medication, whatever the barriers are for that person, or just from a cultural standpoint, they're not interested in taking the medication. When I kind of talk about, well, tell me about your ability to take the medications, that really leads to a great discussion with the patient.
I would just add to this, one of my favorite wisdom from the clinic statements comes from a doc at Metro, Dr. Jim Campbell. He's a geriatrician, and what Jim says is the way he talks to his patients about this is he combines it with a sort of common ground and norming statement. And he says, look, everybody's unable to take their medicine sometimes, including me. How often does that happen for you? Which doesn't sound like, how often are you not following my orders, right? How often do you stick to the prescription exactly the way I told you to, right? It sort of takes that, sort of authoritative part out, and it really normalizes lapses in medication taking, and and it's also very humble. So I think it sort of hits all those things that Joshua was talking about.
Mm-hmm. Well, I have another question. Can either of you or maybe others elaborate on when we might consider using a peer support program versus a community health worker, and maybe they're a little bit of both?
Great. I think that's a great question, and I think Dr. Dungan, I'm a big team-based care person. There are things that you can learn from peers. For sure, we often talk about, even in our diabetes education programs, sometimes it's not what the person up front is saying, it's what the person is whispering to you on the side that you remember even better, right? And those kind of real world experiences. So definitely peer education has a huge role. And the more that we can build that out, what we find is that there's a lot of patients who are interested in working with other patients. So peer-led support, definitely, a part of a team-based approach to diabetes care. And then community health workers very similarly provide a similar level of support. And so I think it's kind of a both and. If you have the opportunity to do both, I think that's wonderful. If you only have the opportunity to do one or the other, just doing one of them, I think will provide an adequate level of care. But if you can do both, I think that's even that next level.
Mm-hmm. Right.
Joshua, I had a question for you, and thanks for a great presentation. And going back to something you said initially that's kind of stuck with me, and that's the issue of trust. The vast majority of my patients are older African Americans, and many of them have chronic illnesses. And the thing I've been facing over the last couple of weeks is, they'll ask me, do you trust the vaccine? And I said, well, I've gotten it myself. My family members have gotten it. Everyone here in clinic has gotten it. And as they move into the age categories where they're eligible here in Ohio, I said, yeah, I would urge you to get it, because the risk is relatively low compared to actually getting the disease. But you can kind of feel the suspicion, not about what I said, but what they've heard elsewhere. I'm just wondering, do you find that with diabetes as well, especially with some of the newer therapies? Insulin is a widely accepted established treatment, metformin. But when you start talking about Jardiance and Farxiga or whatever it happens to be, there's a lot of skepticism around that. How does that manifest in your practice?
Yeah, so I would say, Gautam, that, or Dr. Rao, that all the medications, there's skepticism around them. I get just as much skepticism from metformin. I don't know if you've seen some of the Facebook posts and other posts out there for metformin on the internet, as I do with some of the newer medications. In all honesty, some of the newer medications, because people have seen them on the TV, they're usually a little bit more open to them than some of the older standbys in some ways. But I think what is central to your question there is trust. Right, that's what's really central to that question. And I won't answer this in a diabetes way. I'll answer it, kind of on the line that you were going there around COVID. And what we've seen here locally, I'm a part of a couple, kind of groups trying to really increase vaccination in minority communities. And what we've heard, particularly from older patients, which is really interesting, and this is like 65 plus in focus groups, as well as some community stakeholders, is that they do actually want to hear from their doctors. Right? Like they actually want to hear from their doctors, and want to hear the perspective. So one, I'm very glad that you're kind of going through that and discussing that, because, we've talked to, like I said, some stakeholder groups, as well as some community members about, well, tell us about our posters and tell us about our campaign and tell us about this and being on TV and all these different things. They said, we don't really care about any of that. We want to talk to our primary care doctor about it, and then for them to inform us. Right. And I think that that's all around trust, right? Like that is the person they trust. The second piece to that, though, and this kind of comes back to the peer support groups, is that look, I'm working 7 a.m. to 9 p.m. Trying to improve vaccination rates and all this kind of different stuff in minority communities. My mom gets the vaccine, sends it out to 50 of her closest friends. She's got 6 people who were, I'm not taking this vaccine, no way. She calls them up, talks to them. They've all got vaccinated, right? And so I tell my mom, look, Mom, you're doing a much better job than what I'm doing, even with an MD and an MPH and all these other things, right? And that kind of comes back to that peer support. As I think as a huge option that we need to take more advantage of, particularly in diabetes care, where people are really will listen to someone who's kind of had the same experiences that they've had, who's the same age and kind of going through some of those same things. And I think that that's the potential opportunity there, Dr. Rao.
All right, well, thanks for that great discussion. I'd like to segue to our case study now.
Her cardiologist is heavily in research, and I actually see her more than he does. And I think they defer to me on most of this. And I was pretty reluctant. I'll be interested in maybe what Dr. Joseph thinks, but.
Yeah, so you got a few experts on the call regarding the both the SGLT2
okay.
And the GLP-1 agonist. I think the SGLT2, I think 30 is kind of right at that number, right? We have pretty good clinical trial evidence down to 30 now, but 30 is kind of right at that cutoff. I'd love to hear what Dr. Dungan has to say about that, as someone who's kind of led some of these clinical trials.
Yeah, there were some sub-analyses of some of these clinical trials, because they mostly tried to exclude people with 30, but some of them dipped down below 30, and you could sort of conjecture that maybe there is some benefit in terms of heart failure even below 30. You certainly won't get glucose control at the CGFR. But then what and I don't like to be in the business of saying, okay, well, just because you're 87, then we just make you comfort care. I do think it would probably add complexity more so than benefit.
I would just add, so we recently published a paper in Journal of the American Geriatric Society looking at cardiovascular risk factors, especially in this oldest age group. So it's observational data, but we had sort of a unique cohort that had, I think, greater than 20,000 persons over the age of 80, which is really sort of unheard of. And in that group, one of the findings was that the traditionally defined cardiovascular risk factors were not really strong predictors of outcome at all once a person reaches this age cohort. So that it really sort of draws into question. And notably, one of the findings that stood out was that in our sample, which was Northeast Ohioans, that statins really seem to not have an influence on cardiovascular risk outcomes in this, really large 20-year cohort of folks over the age of 80. So I think there's some observational data support for what Kathleen is saying there, in that things change with the way people's bodies work when they reach that age. The one thing in there, and I was going to ask this to Dr. Brody, and maybe I just missed it, was whether she had any history of smoking, because the one risk factor that persisted in our data, even among folks over the age of 85, was smoking. And so that even after 85, smokers did worse than non-smokers. So it was the one thing, it was like, well, if there is something, like, that's one thing you could still address in a person who's that age, and there would still be some potential benefit.
She is still having a few cigarettes a day. She is a long-term smoker. And remarkably, her heart failure remains rock solid. She does take aspirin, warfarin, atorvastatin, metoprolol, and a small dose of spironolactone and Lasix. She can't tolerate the ACEs or the ARBs because of hyperkalemia. So she's not going to give up her few cigarettes.
And sometimes at this age, if I really need to use something, I would think about a DPP-4 inhibitor because they're so well tolerated. But in her case, you'd also want to be very careful about that because of the heart failure signal, at least in a couple of at least with saxagliptin and maybe alogliptin, even though we don't have a mechanism. So I agree that it's kind of, you're sort of stuck, that, you're going to have to, if you do decide at some point that maybe she needs to be treated, which I clearly agree that she doesn't need any medicine right now, that would have to be a very careful discussion.
I had one question, along those lines, Kathleen, for Dr. Brody. Let's say that she did pump up to 9 or something, or 8.5, or just something, above the comfort level in that kind of shared decision-making approach that we recommend from ADA guidelines for someone that age. Would a once weekly GLP-1 agonist, be appropriate? We have some that are, kind of independent of GFR criteria. Kind of, I'm thinking kind of ease of use, once a week is, not, for Dr. Brody, Dr. Dungan, love to hear your thoughts on that as well.
I think with her mental status right now, she could probably learn that and do that. We could get a nurse in there to confirm that she was doing it properly, and maybe do the first few with her, or follow her periodically, or even do it once a week, probably. So I think current, she could do that. The daily might be difficult. What is your limit on her GFR as far as implementing, like Trulicity or?
I've definitely used GLP-1s below eGFRs of 30. In her case, you'd want to be very careful that you're avoiding dehydration. I might even, you know, check a creatinine in a week, even though that's not really part of the label, but just to be sure that she's not getting dehydrated, because that's the biggest concern. You know, if she were to get nauseated and then have trouble with acute kidney injury. But it would be pretty simple and a home health nurse could do it, and as long as she could tolerate it.
I mean, I don't know if anybody saw the New England Journal paper this week on GLP-1s in folks without diabetes, sort of in overweight, obese folks. It was this sort of 68-week double-blind RCT that showed tremendous benefit. So I think that the question, like, to GLP-1 or not to GLP-1 will be, you know, one of the biggest questions facing primary care physicians in the next 12 months. You know, the $850 a month cost for many folks is going to be a really big deal, especially since we're showing benefit in younger patients without disease. I think this is going to end up being like a really, really big deal this year. And it also has an intersection with disparities in trust, because there, you know, trust worries sort of skyrocket when you're talking about medicines that can cost $1,000 a month. So I think that's, you know, this will be something that we'll be dealing with for many years to come.
So Adam, just on that note, exenatide and I think liraglutide are going generic. They lose their patent protection midway through 2023. So still a ways off, obviously 2.5 years or so. And then, of course, it takes a year or so for the price to even start to come down. So I'm actually kind of hopeful that that we'll start to get a more reasonable cost. There's no reason they should cost nearly as much as they do.
Okay, so we are headed to the top of the hour, and I know I wanted to leave a minute or so for our wrap up. Jessie, do you want to take this from here?
Thank you. Thanks everyone for a great discussion. Just a few reminders. You can always catch the recordings of the current clinic on our website, cardio.org. You do need to register for an account to view the current clinics, but you can also watch any of the previous Cardio TeleECHO clinics there as well. And then just the usual reminders, you should have the post-clinic survey from today's session already in your inbox. And then I had also sent out the contact demographic form late yesterday afternoon. Thanks to those of you who have already filled it out. That's great. Just a reminder that we'll use that information to share a contact sheet with this specific cohort at the end of the series. If there's a reason that you'd like to opt out and you don't want your information listed there, please just feel free to email me and I will remove you from the list. And I think with that, that's it. We look forward to next week. Next week's topic will be motivational interviewing in the context of type 2 diabetes with Dr. Werner. So thanks again, everyone, and have a great rest of your day.
Thanks, everyone.